When you're thinking about meconium aspiration syndrome, that's another time when you're going to be seeing respiratory distress in the newborn. And what occurs during meconium aspiration is that the respiratory tract becomes lodged with meconium. And so, oftentimes, when a woman has a ruptured bag of water and then the amniotic fluid is green or has green with particulates in it or it's thick like pea soup, this is when we're going to see those respiratory aspiration syndromes occurring. What occurs then afterward is the infant might do well for a while, but then eventually what we see is respiratory distress developing with the persistent pulmonary hypertension. We used to utilize endotracheal suctioning with any baby that had meconium aspiration or had meconium stained amniotic fluid. And what we found out is that if you had a vigorous infant and you were doing ET suctioning, then what would happen is that you would push more meconium down into the endotracheal airways. So the only time you're going to see these infants suctioned is if they are non-vigorous. We see meconium aspiration syndrome very often with post-dates or post-maturity infants. So the management is going to be supportive, so utilizing oxygen, either oxygen cannula, oxygen hood, and then surfactant to help keep those airways open. We can see meconium aspiration syndrome. Oftentimes, these infants will have to be on IV antibiotics for 7 to 10 days, and those drugs of choice are going to be like your ampicillin and gentamicin. Complications that are associated with oxygen therapy. So we need to be cautious when we are administering oxygen. We don't want to give these newborns too much oxygen. What we can see are listed out up here. So the retinopathy of prematurity. This occurs when normal retinal vessels begin to form in the fetus's eyes around 16 weeks of age, and then they are fully matured between 42 and 43 weeks after conception. So what happens with the retinopathy of prematurity is that it develops when oxygen tensions are too high, and it's very important if you have an infant that has received or receiving high flow oxygen, that they have an ophthalmic follow-up so that we're getting their eyes looked at. And really the thing behind this is that prevention is the key. So if we don't do it, we're not going to run those risks. The bronchopulmonary dysplasia is a chronic pulmonary condition, and it occurs from pressure of ventilations and oxygen toxicity. So when you are thinking about these newborns being on ventilators, we need to make sure that we know how to use them and we're using them properly. What happens with the bronchopulmonary dysplasia is that with these premature infants, they don't have the surfactant, and so they end up having like a fluid volume overload. If we give that exogenous surfactant or the artificial surfactant, and our mom has received steroid therapy in the prenatal period, we see decreased incidence of that. So again, it's getting this noted, getting proper treatment, early treatment to have better outcomes. I talked already about patent ductus arteriosus. With the germinal matrix hemorrhage, intraventricular hemorrhage, what we see is this is the most common cause of brain injury in our neonates, and it is most severe in both short and long-term outcomes. So if this occurs, we see some pretty poor outcomes both in the short and long-term end of things. With the GMHIH, what occurs is that there's intracranial hemorrhage in these neonates. The germinal matrix then is a loose network of cells that is supplied with thin-walled vessels, and it lies beneath the ventricles of the brain. It's very vulnerable to changes in cerebral blood flow, in blood pressure, and so infants who experience this are usually less than 34 weeks gestation and have experienced some type of hypoxic event, either birth asphyxia, respiratory distress syndrome, or some type of event that causes impaired venous return. With necrotizing enterocolitis, the risk factors are listed out in your book, but it is an intestinal ischemia due to asphyxia, so it's again an anoxic event, and bacterial colonization occurs With the necrotizing enterocolitis, typically enteral feedings are going to be the key players in this. Because that causes bacterial proliferation. So we really rarely see the necrotizing enterocolitis in breastfed babies. So the following slides then that you have talk a little bit more in depth about the disorders. It talks about management and treatment, so make sure that you take a look at those and are cognizant of what you will be seeing for treatment options, as well as additional preventions other than what I have already talked about. A lot of times what we see is anticipatory guidance for our parents, so we want to make sure that we have some type of idea of how we can help the parents and help them cope with what is happening to their neonate. As far as different types of infections, really what we see is a presence of microorganisms in the blood or other tissues of the newborn. And some of the risk factors, as far as maternal risk factors, if you look on table 28.2, you'll see that there's maternal risk factors such as low socioeconomic status, poor prenatal care, poor nutrition, substance abuse. During the intrapartum period, there's a few things, maternal fever, premature rupture of membranes, prolonged labor, premature labor, urinary tract infections in the mom. And then with the neonatal side of things, twin gestation or multiples, birth asphyxia, meconium aspiration, low birth weight, those are all going to play a part in infections and our neonates. So when we are looking at some of the common causes, group B strep, Haemophilus influenza, E. coli, strep pneumoniae, lots of different ones are listed out here for you. With sepsis or septicemia, obviously it's just a generalized infection of the bloodstream, and it can lead to meningitis, DIC, septic shock, and death. So we really want to make sure that we are getting these infants treated with IV antibiotics and taken care of as soon as we can. With the septic shock, we see a decreasing blood pressure, grayer mottled appearance, cool extremities, irregular rapid respirations, changes in pulse. So the signs and symptoms, when you look at those, think of what you see when you have an adult patient with shock. We want to make sure that we do get blood work going right away. So when we're looking at sepsis and septic shock, it's really the clinical signs don't always show up right away. Lethargy, poor feeding, poor weight gain, those types of things. Nurses oftentimes just have that gut feeling that this infant isn't doing well, or this infant has changed from the day before. So the lab results or lab studies that we then are going to want to look at are blood cultures, cerebral spinal fluid, UAs, CBCs with differentials, looking at C-reactive proteins, hypoglycemia. So just different things to rule out what may be going on. So prevention, primary prevention, number one, always hand hygiene, washing your hands, maintaining aseptic technique, limiting visitors, especially when you are in the flu season. Curative measures, breastfeeding. We know that breastfeeding releases those protective antibodies, so IgA. Administration of anti-infectives, and really the two anti-infectives that you will see most often are ampicillin and gentamicin. Ampicillin can be given IV push slowly. IV gentamicin, however, is very ototoxic. It comes typically 80 milligrams per ml, so you want to make sure that when you mix these drugs, you are double checking them with someone, because you are working with such a tiny patient. And then maintaining fluid and electrolyte imbalance. Want to make sure that we are using isolation precautions as well, getting all of our equipment cleaned thoroughly. Our NICUs are going to be really a high risk area simply because of all of the infants that are in the NICU and all the equipment that's being used and maybe not cleaned properly. Toxoplasmosis, so thinking about those torch infections that we initially talked about in women's health, Toxoplasmosis is often found in cats, and so cat litter or an area where there's lots of cat traffic. It can also be found in undercooked meat and those types of things. So what we see with birth, typically they're asymptomatic at birth, but can lead into hydrocephalus, microcephaly, cerebral calcification, cerebral palsy. Other symptoms that you might notice with this fetus is a preterm delivery, intrauterine growth restriction, thrombocytopenia, lots of different things going on. So what we really have to focus on is the treatment of the anemia. So folic acid supplementation is going to be really important for that. And what we're going to do is use supplemental treatment for at least a year. So lots of different things to think about with these common torch infections. So gonorrhea, we talked about, and with gonorrhea, it ascends up the birth canal and then will eventually contaminate the fetus. And so it does have it can either be transferred that way after rupture of membranes, or we can see transplacental transfer if mom has not been treated. So again, primary interventions. So primarily, let's get the mom diagnosed, let's get her treated. Primary prevention, better outcomes for our newborns. So with the infection, we see lots of different things going on. We can have septicemia, meningitis. So what we will use is ceftriaxone, and that ceftriaxone the baby will be on for typically 7 days, IV therapy. Syphilis is another torch that we've talked about, and if untreated, 50% of neonates will have symptomatic syphilis. So the risk to the fetus really depends on what stage the mother is in. So we see risk factors for neonatal syphilis really related back to mom and what mom's history is. So if she has those high-risk behaviors and high-risk tendencies, we can see that transferring onto the baby. If mom has active genital syphilis, then we're going to be taking her to C-section, but oftentimes with these high-risk behaviors, this may be somebody that we don't even see and she delivers on the street. So early signs and symptoms are listed out, as well as the treatment. If mom's treatment has been adequate prior to delivery, and the serologic tests of the infant don't show syphilis, generally we're not going to use any kind of treatment. Otherwise, what we do is hospitalization within a 10-day course of IV antibiotics, and again, using things like ampicillin, gentamicin. When you're looking at early signs and symptoms, it talks about a copper maculopapular rash. And that usually is found on the hands and soles of the feet, sometimes in the diaper area. And so those will be things that you want to be watching for. With varicella zoster, that's the virus that's responsible for chickenpox and shingles. If mom has an infection in the first part of pregnancy, unfortunately, this can cross the placental barrier. So what we see happening is if mom is exposed early in pregnancy, we do see outcomes with that newborn or with that fetus. So if we have an infection in the last 3 weeks or the latter part of pregnancy, then we're going to give her that varicella zoster immunoglobulin. And what that will help will help reduce the effects of that virus on the preterm fetus. Most women are typically immune to varicella zoster, so this isn't something that you see. It's not something very common. But if you do see this, or if you hear of a pregnant woman that's been exposed, we do want to start treating her with the immune globulins within 72 hours of exposure. Hepatitis B can be transmitted transplacentally. It can be transmitted serum to serum, or it can be transmitted with contaminated urine and feces, vaginal secretions, semen. And we see hepatitis B as being associated with preterm delivery. So when we're looking for treatment, the hepatitis B immunoglobulin is what we would use for a newborn that has been exposed, and so we want to give that within 12 hours of birth. If you're looking on the other side of the preventative primary prevention, the hepatitis B vaccine series is usually always started in the hospital, and then they will use the follow-up series They'll continue to get those series with the normal newborn, infant, first year of life vaccinations. When we are administering both of these medications, we do want to make sure we use 2 different sites for the injection, so maybe one in one leg, one in the other. We will continue on talking with HIV during the next presentation. Thanks so much.